Thank you very much. So my name is Dr. Jo Brady. I'm a consultant in palliative medicine and I work in Barnet in the community seeing patients in their own homes. And I also work at Barnet Hospital. And I just want to pick up on something Yvette said, quoting me saying this was like a party. I realise that makes me sound rather sad, but what you have to understand is that often, I think you perhaps can relate to this, often when you're looking after somebody who's dying, you can feel quite alone. And actually, it's amazing to see how many people are invested in end-of-life care. And for me, I'm so grateful for the CEPM bringing this meeting together because I look around the room and there are all the people I work with, but I've never seen everybody in a room together. I can see Jewish Care, I can see Mental Health, London Ambulance, my colleagues from palliative care, a whole range of people. So I think this is a really great opportunity for us. So like you say, this is the last few minutes and then you all get to have a break. So I'll be as brief as I can, but I'm not known for my briefness, but I'll do my very, very best. They asked me to talk about the Dying Without Dignity report and just thinking about what we can learn from stories. So I'm just going to explain to you what the Dying Without Dignity report is and talk about the themes that come out of that. And I just want that then really to be a platform for the discussions you are going to have, the work you guys are going to do. And I want you to reflect on the themes I've talked about, think about your own experiences, think about how we can work together to try and overcome some of the challenges that we face and think about what are our priorities, both in Barnet and the wider STP priorities. So really I'm here to start that conversation thinking about the good, the bad and the ugly. I'm not naming names. So just a background to the Dying Without Dignity report. We know that about 500,000 people die in the UK every year. And as Caroline has already said, the majority of those 3/4 are not sudden. They are expected. So we have a huge opportunity to make a difference and provide palliative care. And so we've got the potential to improve the care experience for 355,000 people. Now, I'm not as good at numbers as Caroline and Penny, because when I tried to figure out how many people there was in Barnet, I gave up trying. But it felt like it was a lot of people, and I think you've now said 1,800 people. If you're trying to think about how you can make improvements, where do you go to look for inspiration? Well, in the last few years, there's been a huge amount of reports, guidance, and there's a list here, and you're welcome to go and read these documents. There's some excellent documentation out there. But trying to think about how you then translate that into practice can be quite tricky. So just for this few minutes, we just want to put a spotlight on one particular report and see if that can be a platform really for our discussions. So it's this report. It's not the cheeriest report. It is an ombudsman report about end-of-life care. So essentially, if you have complaints in end-of-life and they're not resolved locally, they go up to the ombudsman. So the ombudsman reviewed end-of-life complaints. They reviewed a lot of them, and they essentially felt there were 6 main themes about end-of-life complaints. And they wrote this report illustrating those themes based around 12 cases. And if you read that report, and I haven't got time to go into it right now, you would expect it, being ombudsman, that the cases and the stories you hear are real extreme, horrible stories. But actually, sadly, I felt lots of the stories felt very familiar. They actually felt like things I came across. They actually feel an awful lot like some of the stories that I've seen written on the table. There's a particular story out there from London Ambulance, and it could easily find its way into this document here. To quote that report, as the independent organisation responsible for investigating complaints about the NHS, we see tragic cases where people's suffering could have been avoided or lessened with the right care and treatment as they approach the end of their lives. And the anguish that that causes them and their loved ones is unimaginable. The truth is, end-of-life care is sadly a recurring and consistent theme in their casework. So why look at a case about reports about complaints? Well, I think the reason most people complain is because they don't want other people to go through the experience that they have. They want us to learn. And that's really the rationale for looking at these cases and looking at these themes and trying to take the themes from here to inform our discussions and our debate. I am aware that that's a little bit doom and gloom, but I do work in the land of palliative care, so I'm quite comfortable with doom and gloom. I do just want to take 1 minute to acknowledge that I think we do a lot of end-of-life care incredibly well. And I hear that every day in my day at work and all through the MCLG meetings that we have been to. But I think we don't get it right every single time. And I think that that's what we want to do, is try and get it right every single time. But just for one moment, I just want to put my hands up and applaud you for all the good work that you do so far. But now back to the doom and gloom. Sorry, didn't last very long, the positivity. So in this report, they came up with 6 themes for end-of-life care. And if I had more time, I would do a shout-out and see how quickly you can get the 6 themes. But in the interest of time, I'm just going to give you the answers. Oh, or not give you the answers. Oh, there you go. So the 6 themes for end-of-life complaints were not recognising people are dying, not responding to their needs, poor symptom control, poor communication, inadequate out-of-hours services, poor care planning, and delays in diagnosis and referrals for treatment. Sorry, it's not going forwards. Okay, so just taking the first one, not recognising people are dying or not responding to their needs. If we don't recognise that somebody might be approaching the end of their life, then we haven't got the opportunity to plan. We can't write our CMC record. We can't coordinate that care. And then people tend to have more crises and there's more distress, and we become very reactive rather than proactive. So what is it we're asking you to actually recognise? Well, we're asking you to recognise the last phase of life, and we use phase rather than put a number on it. Gold standard framework has been mentioned. That often thinks about the last year of life. Would you be surprised if they died? The other thing I think we need to recognise is those last days of life, those last moments of life. And then rather than obsessing about timeframes, it's about recognising need. So I think it's more about recognising the possibility that this person might be entering the last phase of their life. It might be possible. And therefore, from there, having some conversations with them about what's important to them, what are their priorities, what are their wishes. I'm quite obsessed with Atul Gawande. He wrote a book, Being Mortal, and he is now the framework for how I approach these conversations. I might see somebody I think might be entering the last phase of their life, and I will say to them, what is your understanding of your situation? And then I help put the bits of the jigsaw puzzle together to help them see what I see, if that's appropriate. And then I say to them, given that, what are your priorities? What do you want? What do you not want to happen? In the Dying Without Dignity report, one of the examples they gave really reminded me of Mr. Stoical, for those people who've been to the MCLG meetings in the months leading up to this. So this is a real story, but he could easily be Mr. Stoical. 60-year-old gentleman, poor circulation, reduced mobility, kidney failure, lots of different medical teams involved, primary care, secondary care, and he started getting worse, deteriorating. Symptoms, pain, vomiting, wife finding it hard to care for him. She rang a hospice, said, can you help me? They approached the GP, who said, well, not yet. They're still thinking about heart surgery. We'll wait. 4 months later, having struggled on for 4 months, district nurses became involved and brought him to a gold standard framework meeting, and he died 3 days later. And his wife said they were all interested in their own bit, but not the person in the middle, and I needed them to pull together, all work together and agree a plan. So I think we need to worry less about having a curative approach and then marking the transition into a palliative approach. It can be a gradual phased experience. You start thinking they may be entering to the phase. I'll start having those conversations, and then it gradually grows. I think we need to worry less about the specific trajectories, about being sure that this person is now in that final phase. And I think we need to worry about getting it wrong and at least take the risk of initiating conversations and saying, look, I'm worried enough that things are changing for you and what that might mean for you. And taking a more needs-based approach rather than a time-based approach. The second theme was around poor symptom control, people watching their loved ones dying in pain, being agitated, having their symptoms ineffectively or poorly managed. And the case they mentioned here was of a young 29-year-old gentleman with advanced cancer, no more treatment options, who ended up in hospital, and it became very apparent to him, his family and the team that he was dying, and his main priority was to be pain-free. He moved on to a ward, and then he became very agitated, developed pain. They called for a doctor at 1 o'clock in the afternoon, and 12 hours later, no one had been. And his mum went down to A&E and begged and just dragged a doctor out of A&E. So she watched her son suffer for 12 hours, and then he died 2 days later. And she said that pain, she recalled her son pleading with her, Mum, get me out of here. These are the stories we're trying to avoid. The third theme was about communication. I think that comes as no surprise that that's a theme. We know communication is an essential part of good end-of-life care, having open and honest conversations, and then checking what people have taken away. Have they really understood the severity of the situation? And if we don't do that, people often have unrealistic ideas or expectations. They're not sure what they want. And the risk with that is people are missing opportunities with their family to make plans, to make decisions. The fourth theme we've touched upon is out of hours. People are dying and carers suffering because of struggling because of difficulties accessing care and support out of hours. And again, the London Ambulance story on your table really highlights that. I know it's a difficult time, resources are stretched. We need to work really hard on our in-hours work to do as much as we can, as well as we can, to minimise the problems out of hours, because the resource is never going to get bigger out of hours. Poor care planning was the next theme. This is the quote of the report. It talks about a failure of planning care, a lack of coordination, and it highlighted between primary and secondary care. I'm really excited because secondary care is here today and has been at the MCLG meetings. And I think we're making a start about how we can share this job of improving end-of-life care and advanced care planning between primary and secondary care. But I still think there's quite a way to go. And then the final theme was around delays in diagnosis and delays in referrals for treatment. And if we don't refer people because we're worried about getting the timing right, then actually people aren't having the opportunities to do things and make their own choices. I had a woman in clinic just last Thursday who said, I've been begging my oncologist to refer me to you for 3 weeks now. And by the time she pitched up to clinic, she was in absolute crisis and I had to admit her. And it's that sort of thing we're trying to avoid. When I look around the room now, this is what I see. I think you've all done really, really well. It's been an hour and a half of people standing here and talking. And I do apologise, but what we're trying to do is give you some information and guide you towards having some discussions. So the good news now is the tea break is here. You will be going into your group sessions. We'll be asking you to think about the themes I've just talked about, to think about your own experiences. Think about someone you've looked after who has died. What has gone well and what made that work? What has not gone so well? How can we work together to improve it and what are our priorities? So, arise, go forth and conquer. See you after the tea break.